my department is very active in the clinical care of oncology patients, teaching medical students and residents, and clinical and translational research. I specialize in head and neck cancer, but we also have very active research programs in other solid tumors. In previous years, our university hospital has already used cancer biomarkers, biomarker panels, and NGS. We have our own NGS panel. NGS has revolutionized patient care in my practice by serving as a crucial tool for appropriate treatments for our patients. It is remarkable how cancer treatment has progressed from a one-size-fits-all approach to a more personalized strategy. Specific indications for using NGS are based on the European Society of Clinical Actionability Scale (ESCAT) guidelines, which consider the strength of the evidence. The ESCAT defines clinical evidence-based criteria to prioritize genomic alterations as markers to select patients for targeted therapies. This classification system aims to offer a common language for all relevant stakeholders in cancer care and drug development. For example, treatment decisions are not made until NGS results are delivered in specific tumors such as non-small cell lung cancer. We adhere to the ESCAT guidelines to prioritize NGS testing for our patients. This approach is beneficial for common tumors such as non-small cell lung cancer, but also in cases of patients with rare tumors. In non-small cell lung cancer, as we know, molecular alterations are matched with drugs that have demonstrated survival benefits in clinical trials. This is not the case in rare tumors. For instance, I have a young patient with mucoepidermoid carcinoma of the parotid gland that has metastasized to the lungs, a chemotherapy refractory tumor. NGS testing identified a pathogenic HRAS mutation, and this patient has maintained disease control with the targeted therapy tipifarnib for over 3 years. In many cases, NGS testing of progressing lesions can reveal actionable molecular alterations. One example is a breast cancer patient with very aggressive disease. NGS of her progressing liver metastasis showed a PI3K-CA mutation. This patient presented with jaundice and experienced a remarkable turnaround just 1 week after starting targeted therapy, which led to the resolution of jaundice. She enjoyed an everyday life for more than a year afterward. When she experienced progression, we identified an AKT mutation through a liquid biopsy, but unfortunately an AKT inhibitor was not available at that time. In our department, we conduct a molecular tumor board every 2 weeks, bringing together a multidisciplinary team of experts that includes medical oncologists, pathologists, and clinical geneticists. The primary goal of these meetings is to review and discuss complex cases in which molecular insights can significantly enhance patient care. During our sessions, we focus on cases that require clarification of diagnostic findings, which may lead to the recommendation of additional diagnostic testing. We also explore investigational or off-label therapies that could benefit patients facing challenging cancer diagnosis. Our discussions prioritize cases with intricate genomic profiles, unexpected genomic results, and possible biomarkers indicating resistance to standard treatments. Furthermore, we strongly emphasize rare cancers and those with limited systemic treatment options, undergoing genomic profiling. These cancers often present unique challenges, and our MPB aims to identify the most effective strategies for managing such cases. Additionally, our MPB is a crucial resource for the primary care team. It assists them in thoroughly reviewing all genomic profiling reports to ensure comprehensive patient management. Our molecular tumor board seeks to refine treatment strategies through collaborative discussions and ultimately improve clinical outcomes for our patients. We also evaluate cases in which genomic profiling has been utilized to pinpoint non-standard of care treatments, thereby expanding the therapeutic options available for patients. We observe occasionally cases where NGS identifies mutations with a high variant allele frequency. These findings are subsequently referred for germline testing, which may reveal a hereditary predisposition to cancer. Before we refer patients for germline testing, we obtain an informed consent, and we ensure that these findings are identified and disclosed. The incidental findings are verified and classified based on their importance and the availability of beneficial intervention for patients. In terms of genetic testing, we prefer comprehensive genomic profiling versus single gene testing, as the latter identifies alterations confined to a single gene, potentially missing clinically relevant mutations in additional genes. Comprehensive genomic profiling analyzes various genes to identify the main types of genomic alterations contributing to cancer growth. This form of molecular testing generates detailed patient reports offering an in-depth assessment of potential underlying oncogenic drivers. It provides valuable insights, reducing the chances of missed opportunities for diagnosis and treatment. Most people are interested in the prognostic and treatment implications of the NGS findings. They are pleased to hear that treatment will be individualized and in most cases not include chemotherapy. In my country, the situation is not the same for all the hospitals in Greece. There is a gap in the financial reimbursement of numerous biomarkers necessary for treatment decisions. Many hospitals cannot perform an NGS panel and refer patients to outside commercial labs. Unfortunately, many of these labs have not undergone quality assurance and the results are not reliable. New legislation has passed Congress and we expect that reimbursement will take place in the near future. Quality assurance procedures should be implemented to certify labs performing NGS. The future is bright for cancer patients, but reimbursement and quality assurance issues should be addressed.